Welcome. My name is Kelsey Harford, and today I'm going to be talking to you about my MSW research project, which was a scoping review of treatment modalities for young people who have engaged in problematic sexual behavior. As an introduction, across North America, juveniles account for approximately 20% of those charged with sexual offenses. About 50 to 58% of adults who have committed sexual offenses reported beginning this behavior during their adolescence. My methodology for this research was a scoping review, and there were some important ethical considerations to take into account. First of all, it's a potentially controversial topic. Also, there's population vulnerability. Young people who have been studied are also vulnerable due to both their increased likelihood to have experienced abuse or neglect in their lives and the charged nature of their actions. It's essential to take precautions to avoid terminology that is labeling or already contains a great amount of negative connotation, such as the term sex offender. Child problematic sexual behaviors can be defined as behaviors that occur with unexpected frequency in coercive contexts or between youth in different age groups, and that resist intervention, interferes with development, and or are associated with emotional distress. Some behaviors include voyeurism, lewd phone calls, exhibitionism, pedophilia, and rape. And there are some potential problems with definitions like the one I just gave. First is that we must acknowledge that in places where all childhood sexuality is repudiated, there is considerable likelihood that any and all juvenile sexuality will be classified as problematic. We also risk ethnocentric judgments when defining normalcy in childhood or adolescent sexuality. And disciplines of psychology and psychiatry have come to govern the criteria for normal versus abnormal behavior. Those who've engaged in problematic sexual behaviors tend to be predominantly male and heterogeneous in terms of race, ethnicity, religion, and socioeconomic status. We do see common internalizing problems within this population, such as decreased empathy, poor self-esteem, and increased antisocial personality traits. There is no significant difference in terms of their sexual arousal, sexual interests, sexual fantasies, or level of cognitive distortions. Family dysfunction, instability, and violence are commonly correlated with young people who have engaged in sexual offenses, and there's a tendency for poor relationships with parents and fewer instances of warm, positive communication. These young people tend to have a history of victimization and or neglect. In school, we often see academic difficulties as well as learning difficulties, which tend to be overlooked in treatment. Finally, isolation from peers is one of the most commonly cited characteristics seen in young people who sexually abuse. Some general treatment notes to keep in mind. There is a lack of evidence in support of any specific treatment program for young people who engage in problematic sexual behaviors. This may be due to obstacles in obtaining accurate recidivism rates due to the fact that individuals grow up and move, and it's difficult to maintain contact and track progress many years post-treatment. Treatment protocols thus far have been largely based on adult sex offenders, and the National Adolescent Perpetrator Network recognized several key areas that are essential to be addressed in order for treatment to be successful. These areas include establishing a pro-social sexual identity, addressing impulses contributing to problematic behaviors, gathering a history of the victimization of the young person, identifying the cycle of abuse, acquiring trust in others, addressing power and control, and ceasing cognitive distortions in order to accept responsibility. For young people, therapy can be done individually or in a group format. Traumatic experiences, especially early in life, can configure certain thinking models, which in turn can cause behavioral issues. Where there's a primary focus on accepting responsibility for one's abusive actions, the client may be seen as resistant or deceptive if they are unwilling or unable to complete this task. In viewing this through a trauma-informed lens, it may be theorized that the client's sexually abusive behavior is too closely interconnected with their own trauma history for them to be able to process behavior without doing their own trauma work first. Some developmental perspectives to keep in mind. Abusive behavior can be seen as an indication of the individual attempting to meet their basic relational needs. Due to the fact that adolescence is a time of instability and change, it is imperative that we do not pathologize those behaviors or characteristics that are common in most young people, not only those who sexually abuse. Treatment progress focuses on the acquisition of adaptive, pro-social developmental skills that were previously missing from childhood development. From a psychoanalytic view, the research has shown questionable efficacy of this treatment approach. This methodology explores the unconscious mind, which is constructed in childhood through talk therapy. The underlying assumption under this modality is that human emotions, relationships, cognitions, sociality, and behaviors are all influenced by the unconscious mind, which is constructed in early childhood experiences, as well as interactions between the client and their environment. Psychoanalysis believes that the process of externalizing and vocalizing the unconscious motives strips them of the power over the client. A strong therapeutic relationship is essential for a client to allow access to their unconscious mind. Next, I'm going to look at cognitive behavioral therapy, or CBT. Under CBT, the core beliefs about self and others lead to automatic thoughts or cognitive responses mediated by intermediate beliefs that involve attitudes and assumptions. The basis of this intervention involves behavioral modification and psychoeducation. The idea is that by changing one's thoughts, ideas, values, beliefs, and perceptions, one's behavior and emotions will also change. Within this modality, the therapeutic alliance is also very important, and CBT can be done one-on-one or in group setting. There's a 6-step treatment process under CBT. Step 1 is satiation, where a client repeats their problematic sexual thoughts over and over until they're no longer arousing. Step 2 is cognitive restructuring, where the practitioner confronts the thoughts presented regarding why the client felt their sexual behavior was acceptable rather than problematic. Step 3 is covert sensitization, where the client is required to verbalize the thoughts and feelings that led to the offense and then bring to mind an aversive thought or image, for example, prison. Step 4 involves social skills training. Step 5 is sex education. And step 6 is relapse prevention. Multisystemic therapy, or MST, is a family and community-based treatment model that integrates structural and strategic family therapies, behavioral parent training, and cognitive behavioral interventions to reduce adolescent antisocial behavior. The idea in MST is that individual people are influencing and influenced by their wider social environment. The system closest to the young people, for example, their parents or caregivers, tend to have the highest potential to influence them. A young person's system can include the individual and their cognitive processes, family, peers, community, school, and any other professional supports in place. There are 9 key principles within MST. First, we must attempt to understand the connection between the problematic sexual behavior and the larger systemic context. What is causing and or maintaining the problem? 2 is to utilize a strengths-based approach. 3, the promotion of responsible behavior for the client and those in their environment. 4, setting a clear definition of the current problem as well as how progress will be measured. 5, the identification of the sequence of behaviors that leads to problematic sexual behavior and implementing intervention to change that sequence. Number 6, acknowledge the developmental stage that the client is in and tailor treatments to this level. And it's important that this is the developmental stage and not their chronological age. Number 7, the family and/or caregivers are required to provide regular and sometimes daily efforts. Number 8, continuous evaluation of progress by multiple sources close to the client. So this might be the client themselves, parents or caregivers, other family members, and supportive adults. And finally, number 9, the interventions need to be generalizable to broader social contexts for long-term efficacy. The next treatment modality that I'm going to explore is the Good Lives model. This model views problematic sexual behavior as an individual's dysfunctional attempt to obtain their primary human goods, and the primary goods are seen in the chart on this slide. The goal of therapy is to assist clients in finding healthy and pro-social means by which to achieve their preferred primary goods. Primary therapeutic focus is on the present, having the client share insight into their rationale for engaging in problematic sexual behaviors, and then explore the client's understanding of the impact of their problematic sexual behaviors. Next up is restorative justice, which is based on Indigenous healing methodologies, which pursue harmony and balance. Under this approach, it's the community that works to hold the individual accountable. The crime is a harm against the community as a whole and not just one individual. This allows for the person who was offended against to have a voice, and the person who engaged in the problematic sexual behavior to gain a better understanding of how their behaviors have impacted others. Restorative justice ceremonies involves the young person who engaged in the problematic sexual behaviors publicly taking responsibility for the harm caused in a forum where others may also be able to speak their feelings about the situation. And finally, after going over several different treatment modalities, my recommendations moving forward are two-pronged. First is preventative, whereby caregivers provide age-appropriate information to children regarding sex and sexuality. And second, at the intervention stage, which would include specialized education on the impacts of trauma, secure and insecure attachment, and age-appropriate sexual behaviors. While in treatment, the caregiver system as a whole is involved. Practitioners will utilize a trauma-informed lens. Clinicians will work with the young person on pro-social skill building and increase accountability. There will be efforts to identify the triggers for problematic sexual behavior and establish a safety plan on how to intervene in those sequence of events. Where possible, having the person who was offended against involved and allowing them to have a voice. And finally, the young person would leave treatment with a discharge plan and the option to re-access treatment if needed. Some of the limitations and thereby potential for future research, obstacles in obtaining accurate recidivism rates were an ongoing concern. And as I mentioned, the young people grow up and move, and it's difficult to track their progress over the years. In my research, I was unable to differentiate between those who participated in treatment voluntarily versus those who were court mandated. There was little to no information on the neuroatypical population. In fact, this was an exclusionary criteria for a majority of the studies that I looked at. And there was no information on the use of narrative therapy with this population, which could be a good avenue to explore in the future. Finally, here are all of my many references. Please contact me if you would like a list of these references or a copy of this slideshow. I'm happy to provide them, and I hope you enjoyed this presentation.